Welcome to McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum built for residents and fellows from PGY 1 to 5. This is Caitlin Rigg and Bandar Ba, and today's topic is about history and physical examination. By the end of this 10 minutes, learners should be able to discuss key parts of the history and physical exam in a poisoned patient, to determine key persons in history gathering, and to identify self-harming behavior. Let's start with a case. An 82-year-old woman presents with progressive confusion over 3 days. Her spouse reports that she was apparently fine until 1 week ago when she started to feel unwell. He also noticed worsening bruising on her body. I'm sure you have a very long list of possible differential diagnoses that can fit this patient's presentation. What investigations can you order to shorten this list you have in mind? As in any case in medicine, history taking is usually the first and most important step in the process of determining the correct diagnosis. A stable toxicology patient is no exception. In addition to routine questions like time of ingestion, what drugs and their amounts were ingested, and a review of systems, toxicology cases have their own unique elements that are necessary to review. Current medications and any available drugs that could have been used in overdose should be listed according to the worst-case scenario. The age of the patient and past medical history are going to assist in selecting the best type of management early on. For instance, a 92-year-old patient with severe heart failure and renal impairment are not going to tolerate aggressive urine alkalinization to clear ASA toxicity. Therefore, an early decision to go directly to an invasive treatment like hemodialysis might be necessary. Another high-yield question is the specific reason behind this exposure. It's critical that self-harming behavior should be noticed and acted upon by proper psychiatric assessment as necessary. Recurrent similar episodes may give a hint about suicidal ideation, child or elderly negligence or abuse, or even domestic violence. It's necessary to talk to other family members and EMS crews about the event and the scene. Taking collateral history from others may reveal information that otherwise wouldn't be available through the patient. Back to our case. On physical exam of our patient, she appears to be unwell, agitated, and confused. Her vital signs are clearly abnormal. A focused clinical exam is mandatory to further shorten this patient's differential diagnosis. It's important, however, to remember the following tricks in sick, poisoned patients. 1. You should check vital signs frequently and when there is any change in the patient's condition. And 2, the patient should be completely exposed. Here is the list of a focused physical exam by systems for poisoned patients. Notice the general overall appearance of the patient. Are they agitated, confused, unwell, somnolent? What does the patient's skin look and feel like? Each one of these findings gives clues and helps to narrow down your differential diagnosis. Next, look at the patient's eyes. We should note the pupil size and reactivity, and if there's any extra findings like nystagmus, disconjugate gaze, or excessive tearing. While auscultating the chest, notice the presence of any secretions or wheezing that might suggest a cholinergic toxicity. The heart rhythm and rate should also be noted. Listen for bowel sounds and examine the abdomen. This may assist in determining opioid exposure and assess for risks of giving activated charcoal. Masses, like a distended bladder and urinary retention, can reflect an anticholinergic toxidrome. Tenderness in the case of obstruction or perforation in a packer may indicate the need for an emergent surgical intervention. Finally, these are our take-home questions. Question 1. A patient brought by EMS overdosed on her antidepressant medications. She insists to go back home and refuses to stay in the hospital. What should you do? Question 2. What does worst-case scenario in toxicology mean? And question 3. What is the benefit of knowing the time of ingestion?